So now let's talk about a case of ascites. So basically you enter into the case and the patient is having distended abdomen. You are asked to assess the patient and figure out whatever the diagnosis is, and then you have to discuss your findings with the examiner, and then the other discussion will take place. So again, our basic schematics will stay the same. Whatever station you are going in, the first thing you need to study before the exam is that you need to know the various different causes of those of that thing. So there aren't a lot of stuff that's in the abdomen. Either you have spleen, you have liver, you have intestine, or sometimes it develops fluid that is called as ascites, or you have kidneys, or you have bladder. So just memorize the various different causes of their abnormality and all of them. Then you do the examination, and then all of those causes become your differentials. So let's start with the causes of the ascites. So there is a separate video where I have tried to put all of them down, and to help you memorize them, I had this visual mnemonic as well. So basically the most common cause of the ascites is the portal hypertension, which was depicted by this. In the portal hypertension, you have the most common cause is cirrhosis. You could have Budd-Chiari syndrome, which is depicted by these pipes. Then you could have right-sided heart failure. You could have congestive hepatopathy due to that, and along with that the constrictive pericarditis, or some infections such as schistosomiasis that can also lead to the portal hypertension. After that, we said that it could be protein losing enteropathy. It could be due to the kidneys are losing protein due to the nephrotic syndrome, or you are not eating enough proteins. Then we said some bacteria infections such as tuberculosis can cause ascites, and then we talked about the various different malignancies that could be peritoneal carcinomatosis, primary peritoneal mesothelioma, or lymphoma, or in females you can also think of the Meek syndrome down the list in your differentials. Then we talked about the various different miscellaneous causes. So there are lots of ducts within the abdomen, and damage of any of those ducts can lead to the leakage into the abdomen, and that can lead to the ascites as well. Say for example, you could have pancreatic, biliary, chylous, or iatrogenic ascites. So keeping all of these causes in mind whenever you enter into the case, and the case is that of, you find out in the middle of the case that the case is that of ascites, then do find out the other of the other findings, and then correlate them, and then pick some of these. And again, you need to know the details of the investigations, the management plan of all of these, so that when the discussion bit come, you're good to go. So here are your causes. Now let's go to see our patient. So the first thing first, you do the general inspection. You go to the foot end of the patient, you look at the abdomen. Now you would see that the patient has a distended abdomen, and especially those flank, you will see that they are bulging flank, because when he is laying flat, those bulges will have the most of the fluid. So that's why you will have bulging flanks. Also do look for the pedal edema as well while you are there. So basically, if these cirrhotic patients usually some have low albumin as well, so they tend to develop edema. Also look for the cachexia or weight loss that could be suggestive of some malignancies. Also look for the jaundice or any other signs of chronic liver disease, such as lean and thin build with the protruded abdomen. And also look for any febrile look that could be the case of infective case. But again, a general overview, you just put a glance at the patient. You do know it's an abdominal examination, so look for all the clues you can get. Again, in any of these stations, what are you doing? You are basically a detective that has a few stops, and on each stop you get to find a bits and pieces of the findings, and then you correlate all of them. So the first bit is your general inspection that you have done. Now let's go to the hands. We start with the hands, go up, and then from the face we go down. So let's start with the hands. So what findings could you find out in the hands? So you could look for the palmar erythema. If it is there, it is suggestive of the chronic liver disease. You can look for the hysterexis. If that is there, it means that the patient has hepatic encephalopathy. Do look for clubbing, do look for murex line or terry nails. So what are these? So you can find out in the case of hypoalbuminemia, you can find out these murex line, or you can find out the terry nail. So the terry nails are basically the whitish nail bed, whereas at the top you could find out these pinkish area. So terry nails, murex line, or you can also look for the leukonychia, which are these whitish nails. So these whitish dots within the nail, so that's what your leukonychia is. Again, it's just for my memorization because I tend to confuse it with the koilonychia. Do remember the koilonychia are the spoon-shaped nails that are present in the iron deficiency anemia. So whenever there is deficiency of iron, it leads to the spoon-shaped nails. Now, at the hands, you have to find out some findings. Do look for bruising. That could tell you about the coagulopathy, or could tell you that the patient has, some platelets disturbance. And also, in case of the cirrhotic liver, do look for the Dupuytren contractures as well. So all of these findings you can pick up in the hand. So those are that's why these findings are called as peripheral stigmata of the chronic liver disease. Then you go to the arm and forearm. Do look for tattoos, do look for needle marks. So those are going to help you detect that the patient is having some infective course of the liver disease. So those things are good to look for in the arms and forearms. Then after that you go to the face. Now your face, you start going downwards. So in the face, do look for jaundice, icterus. You look in the eyes, you could find out xanthelismas. That could help you that the patient is having hyperlipidemia, and that could be causing the liver disease. Also look for any spider nevi or any rashes over the skin of the face. Do look for any parotid enlargement. That is very, very common in alcoholic liver disease. And also you can also look for the facial telangiectasia that is present in the chronic liver disease. So look for those findings in the face that are going to tell you about the chronic liver disease. So you find out some of the findings at the general impression, then hands, then arms and forearms, going to the face. After you go to the neck and axilla. Now in the neck and axilla, what you are looking for, look for the loss of axillary hairs. So again, it's one of the it is going to tell you about the advanced liver disease or in malnutrition as well. Also look for the lymphadenopathy, which is again which can tell you about any malignancy or a TB. So in those cases you could get a lymphadenopathy as well. Also look for the spider nevi. So if there are spider nevi over the neck, axilla, chest or back, so those are the main sites of the spider nevis. So look for those, and if they are greater than 5 in number, so that is highly suggestive of that the patient is having a chronic liver disease. In cases when it is less than 5, so it could be just benign. So what is a spider nevi? So you have the central arteriole, and after that there are radiating blood vessels from it. So what you do, you tend to in our examination, you put a pin and you block the central arteriole, and what will happen is that all of the structure will collapse, and as soon as you lift the pin from the central arteriole, all of the blood vessels will come back. So that is going to help you to differentiate the spider nevus from the general telangiectasia or the other blood vessels lesion on the skin. So in the neck and axilla, you look for spider nevi, loss of hairs, any lymphadenopathy. Then you go to the chest and back. Again, look for the spider nevus. On the general inspection, you could find out if the patient has gynecomastia. Then again, the gynecomastia, it's just not enough that you just look for it and say, okay, the patient is having gynecomastia. You need to palpate it as well. Look for any nodes, look for any deformity in that. Look for muscle wasting, and look for the scars from the previous procedure, such as the liver biopsy or peritoneal dialysis catheters as well. So those are the things that you look at the chest, as well as you look at the back of the patient. After that, so again find the bits and pieces from here and there, and then you go to the abdomen. So in the abdomen you tend to do all of the examination, inspection, palpation, percussion, auscultation, everything. You look that the patient is having distended abdomen, look for the fluid thrill, shifting dullness, look for the do comment on the umbilicus that it is everted, look for the caput medusae, which are basically dilated abdominal vein that is again showing the portal hypertension. Look for the hepatomegaly, splenomegaly, any tenderness which suggests the spontaneous. If the tenderness is there on the abdominal examination, it could be showing the risk of the spontaneous bacterial peritonitis. And again look for the scars for the biopsy, and laparotomy and paracentesis. Again, if you are a medical fellow, so the most common thing that we miss are the scars, because we don't usually have those in the medical wards. So do look for the scars, because they tend to produce patients with lots of scars, and if you miss them, then again you lose your marks. So do all of the abdominal examination, find bits and pieces from the so basically when you're doing abdominal examination, your maximum information is going to come from here, and all the other station that you have done will provide you other information, which when you combine you can get a diagnosis. And all of the causes that we have studied in the start, you can narrow them down to the fewer differentials, and then those differentials you can discuss with the examiner. Again, in the feet, look for the pedal edema, because these patients tend to have low albumin due to cirrhosis, or even due to the cardiac causes the patient can have pedal edema. Then also look for the pallor, bruises, or any pigmentation changes. So again, once all of them is done, your causes, whatever causes we talked about in the start, so now you have narrowed it down. You have seen that the patient does not have petechia, you've seen that the patient has the peripheral stigmata of the chronic liver disease, and then you palpate the liver and you see that the patient does have a hepatomegaly as well. So you find out that the cause of the ascites in this case is due to the liver, and the liver is causing portal hypertension, and that is causing the ascites. In case if you manage not to find out any peripheral stigmata of the liver disease, and you auscultated the chest, there were crepitations, and then there was a murmur in the heart chest auscultation, and then you can say that okay, this was due to this ascites is due to the heart disease. Again, if it is due to the malignancy, you would be able to find some lymph nodes anywhere in the body, and then you tend to palpate the liver. You could find out liver is enlarged, and then you find out the ascites. Then you can relate it to the in your top differential that it could be due to malignancy, it could be due to TB. So in all of these cases, the causes that you have, those causes will be maneuvered into your differentials. But again, you do need to know the causes, and then once you're put on your differentials, then you need to know the further investigation, management and the safety netting of the patient regarding those differentials. Those are the bits and pieces that you need to study, which we are not going to explain in this video. So in this case, you have a very, very good approach towards a case, and thus you will be golden in a case of ascites. Okay, that would be it. See you in the next video.